Welcome, everybody. I'd like to thank you all for joining our panel today on our pandemic lessons learned in the Americas. I'm Bruce Vitor, the Associate Director for Research Innovation at the Jack D. Gordon Institute for Public Policy at Florida International University. So this panel is in collaboration with the Command Surgeon's Office at the U.S. Southern Command and the Jack D. Gordon Institute for Public Policy, and is co-sponsored by the Florida International University's Extreme Events Institute, the Kimberly Green Latin American Caribbean Center, and the Robert Semple College of Public Health and Social Work's Global Health Consortium. For everyone's knowledge, it's being recorded, and so we will hang this on our YouTube page, as well as on the Security Research Hub, so you can watch this again in the future. And this builds on the previous efforts from the U.S. Southern Command concerning COVID in the Americas, but we'll focus on the lessons learned in policy, health, and finance. So we're lucky to have some of the prominent minds involved in analyzing the effects of the pandemic here with us today. And I'd like to introduce our moderator, the U.S. Southern Command's Deputy Command Surgeon, Dr. Walter Diaz, who's provided oversight for the medical readiness of all uniformed members and DoD civilians working in Latin America and the Caribbean. Dr. Diaz has focused his efforts on enhancing the strategic value of U.S. military medical activities in Latin America and the Caribbean. His efforts include building the operational capacity of partner nation military medical departments and improving the coordination, planning, and execution of the U.S. military humanitarian operations and exercises. These enhanced capabilities enable partner nation self-reliance while strengthening bilateral, regional, and multilateral cooperation. Dr. Diaz has operated in many of the important global health activities, including serving as a program manager for the U.S. Medical Treatment Program in Bogota, Colombia from 2006 to 2009, and is a presenter of the International Committee on Military Medicine at the World Congress in 2015. He has numerous humanitarian and disaster relief missions in Latin America and Caribbean region over the years. And so I'd like to turn it over to him to introduce the rest of the panel. Wally, thank you very much, and over to you.
Well, Mr. Vitor, Colonel Vitor, thank you very much for that very kind introduction. I want to say good morning and good afternoon, depending on where you're signing in from. I want to thank you for attending this Lessons Learned panel. As I was introduced, I'm Wally Diaz. I'm the Deputy Surgeon here, and I'll be your moderator for today. Before we get started, I want to send a special thanks to Florida International University, my latest alma mater, for co-sponsoring this event. FIU really has been at the forefront of engagement and cooperation with our partners in the region and continues to live up to its name, Florida International University, once again. They conduct and co-host many foray and discussions that at times have been led by the president of the university. When the pandemic first hit, it was impossible to meet in person. He led many panels to discuss the way ahead on the pandemic. We'd like to thank all the attendees from our partner nations in the region. Your attendance really enables us to learn from each other and exchange ideas, because what really our aim is that our experiences become lessons learned and not lessons observed. There's no doubt that COVID-19 has changed our entire world and the way we conduct business. We go out to eat or not, and we engage on a personal level. We each have personally and professionally been impacted, some of us tragically and some of us personally, by this disease. The medical, political, and economic challenges that we face are not unique to any country, and we're fighting this battle together. We're learning together, and by conducting these forums and these subject matter expert exchanges, we can share experiences on how to move forward, and now that we're in this pandemic, maybe prevent the next big one. This is why these meetings are so crucial and important. Again, I want to thank Mr. Vitor for that kind introduction, and the future Dr. Fonseca, who is not here. He is the director of the center for allowing us and co-sponsoring this. I will do a very brief introduction for each one of the panelists, and then they can speak. When they finish speaking, I'll introduce the subsequent panelist. This will be in alphabetical order. So since I know that Dr. Aldighieri has logged in, without further ado, Dr. Sylvain Aldighieri is the Deputy Director for Health Emergencies at the Department of Health Emergencies Department at the Pan American Health Organization in Washington, D.C. I first met Dr. Aldighieri several years ago in some of the forums that Southcom participates directly with on sharing health information and collaborating in the hemisphere. And his direct involvement in many of our health emergencies have helped ameliorate or reduce the impact of a lot of things, including going all the way back to when we first met and had a lot of direct connections with PAHO was during the Ebola pandemic in 2014. We had strict collaboration, very close collaboration with the Pan American Health Organization, and it goes back to then. So I want to thank Dr. Aldighieri. I know he was in another meeting and jumped in right away to be the first panelist. So I am going to start with him. And the way we're going to do this is going to be, I'm going to ask a question. This is kind of like a fireside chat. And the panelists will respond to the question. If you have any questions, you can put them in the chat. And as they come in, I may be able to weave them into the discussion. So without further ado, I'm going to start with Dr. Aldighieri. Doctor, buenas tardes.
Mucho gusto. Yes.
You know, PAHO and the Economic Commission for Latin America and Caribbean has really pushed governments to accelerate vaccination processes. That's not just them, that's the World Health Organization, that's other governments that have tried to push the accelerated vaccination. Also wanted to transform health systems and strengthen public investment, among other measures, to control the health crisis in the immediate and short term. PAHO and ECLAC also made suggestions that nations move forward toward a transformative recovery with equality, which is a key, and environmental sustainability in line with the Sustainable Development Goals. In what ways will the new COVID-19 vaccine funding mechanism for member states support this goal?
Thank you for this question. It's a very large question, and you mentioned, Dr. Diaz, the collaboration between PAHO and ECLAC and the Economic Commission for Latin America and the Caribbean. We have published recently a joint report that concluded that economies of the region will only be reactivated if the curve of contagion of the COVID-19 pandemic is flattened. So we are still with this goal, flatten the curve. You would remember what happened 22 months ago. Vaccination is one of the keys to reduce the impact of the pandemic on our societies. However, many countries in the Americas have not yet met the WHO goal of vaccinating 40% of their population by the end of 2021. At the current rate of vaccine absorption, we may have at least 10 countries that won't meet that goal of 40% coverage. One of the main reasons that countries have challenges in meeting that goal is that vaccine demand is very high and the supply is relatively low. The PAHO regional platform for advancing the manufacturing of COVID-19 vaccine and other technologies in the Americas is an initiative that would help us, the region, to meet that challenge. But it's not an immediate solution. At the moment, we have 2 projects for producing vaccines in Latin America and the Caribbean. It's one through the public producer, Biomanguinhos, the Institute of Technology that is part of the Osvaldo Cruz Foundation in Brazil, and one private company, Sanergium Biotech in Argentina. So with the technical support and assistance from PAHO, we plan to accelerate the development and the production of mRNA vaccines. But this production won't start tomorrow. So this is the challenge. In the short term, we have asked producers to expand their distribution of vaccine through COVAX, so we can reach 70 to 90% of vaccination next year. But also we have put our core institution in the center of the assistance to the region with the PAHO revolving fund, which has more than 40 years of experience in buying and distributing vaccines in the Americas. So more than 20 countries of the Americas have expressed interest, and we have already negotiated some 4 million doses for 2021, and we plan to expand much more in 2022. Also, we are working with COVAX and the countries to get more donations to the countries of Latin America and the Caribbean. I'd like to stress the importance of the donations in this continent. For example, 75% of the vaccines that were deployed to Honduras, which is a priority country in Central America, 75% of the vaccines that reach Honduras through the COVAX mechanism are donation of the US government. Almost 80% of the vaccines channeled through COVAX in El Salvador, 80% are also donation of the US government. Other countries are receiving assistance from other nations from the north. For example, Nicaragua, at this moment, 80% of the doses that were channeled to Nicaragua through the COVAX mechanisms are donations from Spain. So the immunizations programs in Latin America and the Caribbean are the tip of the spear for our public health efforts. But they need and still need short-term help with operational funding, logistics, and cold chain. The pandemic has set back routine vaccination. So rolling out new scarce vaccines for adults and elderly persons is adding a new burden on the existing programs of vaccination that for tradition have more targeted the children in our countries. So what I could say that in the medium and long term, as we begin producing COVID vaccines in the region, I mean in Latin America and the Caribbean, and other medical supplies and transform health system, we will advance further, controlling both the deteriorating public health situation and the economic decline that this pandemic has caused. I would stop here. Thank you, Dr. Diaz.
Dr. Aldighieri, that's a very comprehensive answer. And I think that one of the things that PAHO always brings to the table is the credibility. PAHO has enormous credibility when it comes to anything medical in the region. And on many occasions, given that COVAX is one of these mechanisms that comes through the World Health Organization, I think it's also helping on people accepting vaccines because they see them as seeing through COVAX, regardless of who was donating them. So that's a great mechanism. Now, the second question that I have is that, you know, we've seen in the past that Latin American Caribbean region is one of the regions with the highest number of cases and mortality in COVID-19. However, and that's not just in Latin America, in the United States too, vaccine hesitancy remains an issue. What are some of the tools and strategies that can help increase vaccine acceptance in the Latin American and Caribbean regions?
Yeah, no, thank you for this question. And vaccine hesitancy is a complex program, and neither public health authorities nor communication experts have all the answers or even coherent national strategies. This is a fact. We have to continue working with health ministries, but also with religious leaders and trusted national and local figures to explain in positive ways the benefits of the COVID-19 vaccination campaigns. As I said, it's complex. People resist vaccines for reasons including conspiratorial beliefs, deliberate non-conformism or reactance, individualisms, and fear. Each of these requires tailored reasoning to overcome, and all are different, so new layer of complexity. We surveyed health workers in the Caribbean and found that 30% of them had some level of vaccine resistance. So you would imagine what is the negative impact, as now in the Caribbean, we have a surge of cases. I'm thinking about the Eastern Caribbean countries with 30% of the workforce that is not vaccinated against COVID-19 and has to manage patients, a surge of patients with COVID-19. So health authorities make appeals to get vaccinated, but this can also have a boomerang effect among anti-vaccine people, hardening their positions. The reason that this approach, known as explication, doesn't work according to some experts is because the vaccine resistant people are engaging in a form of motivated reasoning that leads them to selectively interpret the data and over information, which is the selective interpretation of the reality. So this is an area incorporating social science where we need better research, community level persuasion, different approaches, and innovative psychologically based public service campaign to increase the vaccine acceptance. I would stop here, my comment here, Dr. Diaz.
Thank you, Dr. Aldighieri. And it's a multi-pronged approach that has to be done for this, as you well say, that we have to kind of explore other ways. The people have offered financial incentives. People have had, spokespeople come to prominent people say, hey, get vaccinated. So like you say, it's not a single answer. And I hope that social researchers, not medical research, social scientists come up with some solid research that kind of points us in a direction. And it's not going to be a panacea, but at least different ways to approach each one of these levels of hesitancy. Thank you very much. The next question is, the pandemic created institutional fragmentation in Latin American and Caribbean because not everybody had access to COVID-19 vaccines. And we need to strengthen regional coordination and integration mechanisms, as well as international cooperation, which we've done with COVAX. Based on your experience, what tools do you think Latin American governments need to use to have more equitable distribution of vaccines?
So first, I would say that all countries in Latin America and the Caribbean have already well-developed national vaccination plans for COVID-19. What many lack are the vaccines and supplies to implement those plans equitably. And today, because of the stresses on national health system related to the pandemic, some countries also need more operational funding and logistics. I think in the first question, I already flagged this, to support the procurement and the delivery of vaccines. The PAHO revolving fund for vaccine is probably one, if not the best tool available for countries of the Americas to implement equitable immunization plans. PAHO buy vaccines in bulk at the best prices available and take care of all the procurement and shipping details on behalf of the member states. This gives countries additional bargaining power with pharmaceutical companies and allows them to obtain more vaccines, but only those allotted to them through a complex, complicated COVAX algorithm that, we have to be very frank, did not take into account our epidemiological situation. As you mentioned in one of your points, the region of the Americas has been the most impacted region, together with Europe, by the COVID-19 pandemic. So I think I have answered your questions regarding the tools that we have in Latin America and the Caribbean.
Absolutely. Thank you very much for that answer. It's a matter of access, and it is a complicated supply chain that delivers some of these vaccines because of cold chain issues. So the more support that could be provided externally, as you point out, for these governments and the purchase on behalf of the governments, I think they'll have a more efficacious implementation of vaccination program. Thank you. And the final question that I have before we move to the next panelist is recognizing that some experts that there may not be enough vaccine, which you just pointed out, to cover the world's population until at least 2023. A lot of healthcare workers are really sprinting a marathon, and supply chain challenges, not just for vaccines, but in general, are driving scarcity on many items. Moving forward, besides vaccines, what advice do you have for some of these healthcare systems to build resiliency? Over.
So I would really share with you our experience at regional level. Of course, we are fully connected to the regional healthcare systems rather than to the global healthcare systems. But to be more resilient, we need a lot of things, including more health workers, invest in human resources, and better funding to retain them. There is a lot of migration of health workers from countries of the south to the north. We know that there are this migration, including in the Caribbean, with excellent nursing schools, and many of the nurses from the Caribbean are moving north because for a better pay. So we need to assist countries to retain them. PAHO recently issued a report on resilient health systems, and it proposed 8 actions to improve the resilience of health systems, taking into consideration the current context of the COVID-19 pandemic. So I would encourage you to do some research on our different pages regarding this report. This report recommends that countries intensify the implementation of the international health regulations core capacities, integrated within more systematic approach to strengthening the essential public health functions and the risk reduction. So this report also suggests assessing the fiscal space for health and the opportunities to improve efficiencies and promote the development of responsive and adaptive health systems. Trying, for example, progressively eliminating out-of-pocket payments at the point of service and increasing the investments in health systems. The bottom line is that the COVID-19 pandemic caused a systemic shock to our health systems. It may take some years to recover from it, but also as we speak about resilience, we speak about, as I tried to highlight, we speak about healthcare workers, and also about specialized healthcare workers. Remember that when we have to increase the number of beds, including the number of ICU beds, we need healthcare workers to staff these beds. And you do not select, train, and supervise in a couple of weeks an ICU nurse. This is an example. You need sometimes years in order to have the highest standard of care that we wish for our societies. So this is this complex package of resiliency of the health systems in the context of the COVID-19 pandemic. I hope that I have covered your question, Dr. Diaz.
Dr. Aldighieri, thank you very much for that comprehensive answer. That it's been one of the efforts of U.S. Southern Command to stimulate the implementation of international health regulations at every step of the way. Anytime our command sergeant visits a country, they say, "Hey, have you submitted yourself to a JEE, a Joint External Evaluation? What have you done to implement them?" And I know that it requires resources. And through the Global Health Security Agenda, which was implemented several years ago, we've had some success, but the international health regulations have come to the forefront of importance now with the pandemic, not just because of sharing information, but also it has some standards regarding healthcare workers. So I think you've hit it right in the head, and thank you very much for your contribution from the Pan American Health Organization International organization perspective. Now what we're going to do is we're going to move on to Mr. Stephen Ault, who is a lecturer in epidemiology in the University of Maryland. And he used to be, one of your colleagues, used to work at the Pan American Health Organization and knows the region very, very well. He's volunteered himself to go through my questions, to collaborate with us and have this sharing moment so we can, as I said before, have some lessons learned and not lessons observed. So without further ado, Mr. Ault, good afternoon and good morning, depending on where you are. The first question for you is, as we work together globally to improve biosecurity and biosurveillance of dangerous pathogens, where should we be focusing? What critical systems do we need to put into place, either at the country level or collectively at the regional or global level? Over.
Thank you very much, Dr. Diaz. And my thanks to Southcom and FIU for the invitation to participate in this panel and discussion. This first question you ask is really quite a complex one. And I'm just going to spend a few minutes to describe my reflections on this and bring in some examples which may be pertinent to the region and some from the region itself. I know we have specialists in biosecurity and biosurveillance that are participating, and I'm sure they will both enhance the discussion later and correct any errors or misstatements I may make. So let me start by saying that the foci where we need to improve biosecurity and biosurveillance of dangerous pathogens, and perhaps enhance and engage NTD surveillance, neglected tropical diseases surveillance, are both at the country level and the local level, municipalities, local health districts, counties, provinces, etc., wherein the public health officials can address various epidemic-prone respiratory diseases such as the SARS and MERS viruses we've seen in the region and globally, mosquito-transmitted viruses, particularly yellow fever, dengue, Zika, and chikungunya, which have caused epidemics in this region and continue to do so, as well as some of the certain NTDs like rabies, Chagas disease, and leishmaniasis, which can cause local outbreaks or local epidemics. Under the international health regulations, countries operate their disease surveillance and response systems from the national level, but the coverage may not easily reach every local level, and local government and local community residents can and have played key roles in the recognition and data capture about suspect cases, diseased animals, and of course in humans as well, and epizootics. So a number of national NTD surveillance, control, and elimination programs in Latin America and in the Caribbean were actually deprioritized during the first year of the epidemic in order to respond course, to the more urgent needs of pandemic response. And these programs, some of them certainly are still struggling to overcome these interruptions and delays in treatment and service delivery and care, and also monitoring for elimination. So we risk the loss of progress made in some NTD program scale-up efforts over the last decades. PAHO's and WHO's programs focusing on NTDs note that globally, 44% of national programs have reported disruptions, with 66% of large-scale treatment programs like preventive mass drug administration reporting disruptions. That's according to a recent PAHO Pulse survey in October, published in October. So through adaptation and response, some country NTD programs like Guyana's have been able to continue implementation. So the same NTD and also child health and immunization programs in the region, which are being challenged by the pandemic, are also living examples of well-established and integrated public health programs, which cover vulnerable or hard-to-reach communities in rural or urban areas, and whose local infrastructure may be able to aid in biosurveillance of pathogens in the future, if not now. Besides the national level, another important level to capture, I believe, is the potential spillover of the animal origin pathogenic viruses to people. So this would be at the level of public parks and nature reserves, as an example. Biosurveillance of this risk can be done with surveys by field teams, which is generally expensive, or by crowdsourcing of observations of sick or dead animals. Brazil's Oswaldo Cruz Foundation in Rio de Janeiro established an innovative program in 2014 with an app called CISGEO, which allows the public who are visiting parks and nature reserves and other wild outdoor locales to report observations of dead monkeys and other wildlife, I believe, or odd behaviors with geo-reference details of the condition and circumstances they've observed. So this serves and can serve as an early alert system or early signals for possible episodics in those primate species, which in the case of yellow fever are both species which are both reservoirs and victims of sylvatic yellow fever. Dr. Aldighieri knows this system and may have additional comments. Additionally, emerging respiratory virus threats can be sampled at the human-animal interface using traditional direct animal sampling of domestic pigs, poultry, and ducks on family farms or in industrial farms or factory farms, or in live markets or wet markets. Recently, such sampling has even been carried out using bioaerosol samplers in live markets in Vietnam and Malaysia. Research has also shown that another type of novel biosurveillance, which can serve as an early warning of COVID-19 outbreaks in geographically bounded communities like dormitories or military barracks or in cities, is the wastewater systems. Wastewater or sewage surveillance for COVID-19 virus has been conducted and found to be useful and can be applied to other pathogens. It's also important to mention a critical global biosurveillance program, the PREDICT project of USAID, which operated from 2005 to 2019. It collected more than 160,000 samples from wildlife across the planet and identified, using genomics, nearly 1,000 previously unknown viruses of animal origin, some of which may have spillover potential. So we need to design and finance ways in which regional and local level biosurveillance can feed into and work with and coordinate with such global initiatives as the PREDICT project represented. Whether these are coordinated by UN agencies like FAO, WHO, and OIE, or other entities like USAID's new Emerging Pandemic Threats Program, or coalitions like CEPI, the Coalition for Epidemic Preparedness Innovations, and the nascent Global Virome Project. So national and local efforts and institutions in our region can also use complementary new tools like Spillover, which is an open sourced browser-based app for wildlife viral risk ranking, which can be used at a regional, national, or local level and can be crowdsourced. I'd like to take a minute to speak about biosecurity, which is rather different, though obviously related to biosurveillance. When wildlife and livestock interactions increase, there are opportunities for spillover of wildlife viruses, as we know, such as avian or porcine influenza viruses, or to domestic poultry and pigs, and of course, possibly to humans. And there are localized drivers of these interactions, which can be monitored or controlled with biosecurity measures. And to be robust, such measures really must rely on cross-sector and transdisciplinary approaches. And for this, perhaps a One Health model or framework can aid in our biosecurity efforts. The researchers, Jory and colleagues, recently described biosecurity measures to reduce wildlife and livestock interactions or mitigate their impact, and include a rather long list of interventions. And I'll just mention a few, but it gives you an idea of the tools we can have and use in this biosecurity toolbox, as it were. So that can include use of sentinel animals, sampling of game animals, wildlife vaccination for certain diseases, and monitoring and control of diseases in wildlife, and reductions of interactions between wildlife and livestock, all to prevent spillovers. So it's important, I think, to note that farm-specific and industry-specific or local biosecurity plans can be developed by such cross-sector and transdisciplinary teams and incorporate measures depending on the pathogens and hosts, of course. National and local authorities can also make use of guidelines and tools from FAO, OIE, and WHO, such as the new Joint Risk Assessment Operational Tool of the Tripartite Zoonoses Guide, which I recommend for people to check out. As well, regionally in the Americas, regional institutions such as PAHO's Panaptosa, which has historically and continues to focus on elimination of foot and mouth disease in cattle, and COMEXA, the Mexican America Commission for the Eradication of the Screwworm Fly, also offer excellent examples of the use of biosecurity measures from which we can learn. Finally, I would like to note, since the PREDICT project was terminated in late 2019 without justification by the previous US president, I think that we need to note that a lesson learned here is that where large and important international initiatives in pandemic prevention, surveillance, and response can be closed by mere political whims, closures which could be long-term, we really must have a regional, national, and local level biosecurity and biosurveillance systems established with strong technical and managerial capacity in place for the long term and well-financed. So that's a bit of a long commentary on the question, but I hope it will provide some insight. Thank you, Colonel.
Mr. Ault, thank you very, very much. That's a very comprehensive answer. And you mentioned a few salient points that we try to focus on here at U.S. Southern Command. In previous in-person biosurveillance conferences, we've tried to focus on the One Health approach and bringing representatives from the OIE, and in addition to bringing Department of Health, bring Department of Agriculture. So we have a cross-section of any of the potential zoonotic diseases that can have crossover. So you've hit on some of the points that we've been emphasizing in our previous conferences. So I really appreciate that comprehensive response. So the next question is, what are the public policy implications of some aspects of COVID-19 transmission, including new knowledge and research on airborne aerosol transmission?
Well, thank you for that important question. I would say that since the pandemic began in late 2019, early 2020, public health scientists and practitioners, as well as clinicians and vaccinologists, have made huge and very rapid advances in clinical and patient care and treatment, preventive measures, and even logistics and supply chain command. However, the learning process was terrible, and we lost over 6 million people to the virus globally, including 1.4 million in the Latin American Caribbean region alone. So public policies during this time have to prevent or control transmission changed almost weekly, I think we can say, in many countries in 2020 and continue really into this year, 2021. Policies were developed by countries, by states or provinces, by municipalities, restricting travel, indoor activities, recommending or mandating actions like hand washing, frequent surface disinfection, depopulation of rooms and indoor spaces, group size restrictions for meetings and gatherings, public or private, physical distancing, the 1 to 2 meter distance recommendations, and the use of protective face masks and more. More recently, vaccine recommendations and mandates are now a critical part of the discussion, and booster recommendations as well. So each of these actions was or is, depending on circumstances, applied to various groups of people, such as young children, teens, the elderly in care homes, immunosuppressed people, the imprisoned, workers in general, or public workers in particular, hospital employees and students, and the general public. This was really due to the urgent nature and need to convey new and important information, and often change exposure behaviors among these various publics, as I would call them, as new scientific recommendations arose. And we need to continue to craft public policies to specific groups of people and places. I would suggest that with respect to airborne transmission, there is a consensus, I would suggest, among a great many public health and occupational health researchers and physician researchers that airborne transmission of COVID virus, SARS-CoV-2, can and does occur, particularly in indoor environments with poor ventilation, rooms in indoor spaces, and also in public or private transport. Airborne transmission represents an important route of infection through infectious drops spread at close distance, and perhaps principally by aerosols, that is, airborne particles that are suspended in a gas. In infectious diseases, these include some of the well-known airborne viruses, such as measles, SARS-CoV-2, of course, and influenza viruses. These aerosols, they're called bioaerosols, include both coarse and fine aerosols, those that are greater than 5 microns in size or less than 5 microns in size, and are inhalable, which is a problem. Fine SARS-CoV-2 virus aerosols are inhalable into the deep lung, which often can result in serious pathology in susceptible individuals. The evidence is also strong that simple common actions such as shouting or talking loudly, coughing and sneezing, singing, and even speaking normally can and does generate coarse and fine COVID-19 virus aerosols, the bioaerosols. These bioaerosols have actually been filmed and measured to travel up to 6 or more meters in indoor spaces, are affected by airflow patterns, and they have been shown to create outbreaks in susceptible peoples in spaces. Various examples have been published. These bioaerosols have been described as like an invisible cigarette smoke in a room or indoor space, floating in slight breezes and slowly sinking or depositing on the floors over hours, but readily inhalable. Whether or not they will cause pathology, of course, is based upon the individual response and susceptibility of the person. It's believed that bioaerosols are able to remain fully infective. This is technically, it's quite difficult to demonstrate, but based on epidemiological evidence, infected for a period of time, depending on environmental circumstances and virus stability. The evidence is strong that prevention or reduction of transmission of these bioaerosols and droplets is possible now and can be implemented by the use of proper face masks. Filtration masks are the best, surgical masks or cloth masks with multiple layers. Also physical distancing, increasing room ventilation or air exchange, and use of indoor air filtration with particular HEPA filters, as well as the potential for and use of air disinfection using UVC upper room lighting. So I would suggest that protective public policies are in need of development and implementation for indoor environments and for outdoor venues with respect to the challenge represented by both droplets and bioaerosols. In the indoor environments, this can include selective or universal masking requirements for minimum fresh air exchange, such as maybe 8 to 10 times an hour, and depending upon occupant density, and or adequate HEPA air filtration systems or air cleaning with UVC lighting in classrooms or other selected indoor spaces. For outdoor venues, such as sporting and music concert events, parties, and weddings, protective policies can include recommended use of face masks and physical distancing in such crowded events. It's here in this arena of bioaerosols, improved room ventilation, indoor air cleaning, or UV disinfection of air, where public policies that carry enforcement capacity with them can play a very important role in reducing the COVID-19 transmission that we have seen. Efforts to craft a sensible, understandable, and flexible public policies really must continue and must adapt to new scientific knowledge and new circumstances, like, for example, the appearance of viral variants of concern. So I hope that gives some food for thought regarding bioaerosols and air ventilation, indoor air ventilation, and indoor air ventilation in general. Thanks again.
Mr. Ault, I want to say thank you for the very simple, as little scientific as possible explanation of what this is, because I've heard it explained on numerous and sundry occasions what the impact of aerosolized, and we start going down scientific rabbit holes and people's eyes go white and say, what is this guy talking about? Yeah. This is a very simple way to say, hey, wear a mask, keep yourselves apart. It's in the air. You're going to breathe it. It's going to go into your lungs. So I really appreciate kind of boiling it down to simple terms that, I plan on using in an elevator speech now. So thank you.
While wearing the mask in the elevator, I hope.
Yeah, exactly. This is why I'm wearing it, So thank you very much.
Sure. Thank you.
Sir, and then what has, you talked a little bit about it earlier, but what has COVID-19 taught us about the global impact of zoonotic infectious diseases?
This is a very challenging and broad question as well, but here are some reflections that I'd like to share with our audience. So certainly this pandemic has taught us that emerging respiratory virus threats are often swift in their impact and their geographic reach. So when we think back on the lockdowns of that mega city called Wuhan, China, and its population of 11 million people, that had to be done or was carried out within a month or two. The rapid spread of the virus to Europe and North America in a matter of weeks in early 2020. Think also that huge initial mortality that we saw in cities in Italy and New York City all occurred within a few months, perhaps 3 or 4 months. So this issue of the swiftness and strong impact of such viruses, the geographic reach is really a critical lesson learned. I think we need to constantly keep in mind. The scientific consensus, of course, is that SARS-CoV-2 virus is an example of a coronavirus, one of several that emerged from and spilled over from a wild animal population, probably bats, and crossed that wildlife-human interface directly or indirectly. With the MERS virus, another coronavirus, we observed the domestic animal-human interface bridged by the virus from camels to humans. With Ebola virus, we've seen it from fruit bats or various primates to humans. And with Marburg virus, from rhesus bats and green monkeys. So outbreaks and deaths were also swift to follow virus spillover in these cases. So we really must be prepared for frequent spillovers and rapid impact of zoonotic infectious diseases. Prepare ourselves with proactive surveillance systems, including a rapid, and I would stress transparent notification of international authorities by or through the country IHR focal point, have trained and experienced field epidemiologists and their multidisciplinary teams ready and engaged, keep those emergency response plans updated. And I'm glad to hear that Dr. Aldighieri said that the Americas is now in a pretty good space with that. We also need to see a financial reserve, a hefty one, I would say, to draw upon without negotiation, without political negotiation, and logistics, of course, the logistics and stock and supply chain systems operating. And last but not least, the healthcare systems with trained staff capable of identification of suspect cases brought into the emergency department The hospital staffs being equipped with adequate PPE and provide airborne infection isolation rooms as needed based upon the bioaerosol discussion I just mentioned. Now, another aspect to this is health communications. Health communication problems and failures have emerged in many nations during this pandemic and during previous epidemics of zoonotic infectious diseases. And perhaps in this pandemic, especially, the challenges of miscommunication given by the fake media that Dr. Aldighieri mentioned, anti-science propaganda, or simply ignorance are really big stones in the road. New tools such as what is called public sentiment analysis using machine learning models applied to tweets in Twitter were, for example, able to detect a 68% upswing in change in anti-Asian sentiment between November 2019 and June 2020 in one study in the USA. So we can use these new tools to give some idea of communication and miscommunication issues and prepare our health communications for that challenge. What have we learned about sound public health communications relevant to COVID-19 and other zoonotic infectious diseases? Dr. Aldighieri mentioned a few, and I would add, sort of on a more specific stage, we have learned that there needs to be a reliance on a trusted public source, which can range from a trusted public health agency to popular figures like actors or singers or others, who are conveying accurate information, and even to one's local barber or perhaps hairdresser, as well as knowledgeable family and friends. Keep your health messages short and simple, like we recommend a vaccine. Understand the concerns of the public and each family member. Knowing the level of distrust or hesitation can be great. Whether you are a health worker or a clinician, listen with empathy and practice compassion. It's not easy. We're not used to thinking in these terms, perhaps, but empathy and practicing compassion are really important in these pandemic times, and to engage with those we love and who are at risk. So also ask to share information and your perspective when you have conversations one-on-one, for example. Share your personal practices with, say, or about mask wearing or physical distancing or using indoor spaces, and your personal vaccination experiences. Don't forget about talking about your childhood vaccines and how well that went, and the COVID-19 jabs that we're getting today. Help people to what they call find their why. That is, why should I do or not do this or that behavior? If they agree with the message, help them get the resources, whether it be soap and water or hand sanitizer, or even more importantly, proper face masks and safe vaccinations. So these, I think, are some reflections on and some lessons learned about zoonotic diseases and how to perhaps address, in part, this challenge. Thank you, Colonel.
Thank you very much, Mr. Ault. That's been, it's funny, your response, because I find myself using some of that same rationale with some of my friends that had some hesitancy in accepting the vaccine. So I think this is a great place to gather some tools for our toolbox as we engage and do the community's duty, because we're all community. If somebody is having, issues with it, well, talk to them. That's what friends are for. It's not just to go to a barbecue or be there in the good times, say, hey, I feel these are my feelings. This is why. Use it fact-based and unemotional. And I think that's the best argument. So thank you.
You're welcome.
The last question is for you is the pandemic has certainly prompted a greater discussion on health disparity and in different communities. We've seen a lot more discussion of that than in the past. Do you think COVID-19 will prompt health systems to approach health disparities in a different way? Or what are some of the best practices to address health disparities and inequities?
Yes, certainly. Beginning early last year, a spotlight on health disparities in North America and in Latin America and the Caribbean, has been shown or by affected minority communities and other high-risk populations, and by community leaders and media, particularly social media, as well as researchers, about the clear disparities which arose in 2020 and continue to arise yet today with respect to, say, COVID-19 mortality and morbidity, healthcare services access and services delivery, and now vaccine access. So I think one of the fundamental points that we need to constantly remember, keep in our minds and in our discussions and planning is who are these disenfranchised or those that are suffering from such disparities in the LAC region, in one's nation, in one's state or province. So disparities in local, such as county level vaccination rates, have been linked to disadvantage and to hesitancy, vaccine hesitancy. So disparity definitely varies by country and local area and by the health services delivered, be it simply disparity in access to frequency of health visits or disease screening or vaccinations. But survey results in epidemiological research has shown it's usually among what is actually a fairly large group of people. And I'm going to mention these with the idea that we need to keep sort of lists like this in mind as we do our planning and our work. So disadvantaged communities or groups can include people of color, brown, Black, Asians. I'm thinking particularly of when Donald Trump constantly used the phrase the China virus in the media and in speeches in a very derogatory manner. Women, who are often both challenged with being the family caretakers, breadwinners, but also the gender, which is often tightly controlled by an ignorant male hierarchy. The rural poor of any skin color and other disadvantaged populations or groups, including indigenous communities, of which there are many, tens of millions in the Americas, ethnic minorities, those who speak foreign languages, quote unquote, other languages, aside from the principal one in the country, the very wide LGBTQ plus community, and other populations such as the disabled, prisoners, laborers, migrants, and refugees. Some now argue that younger children, say under age 12 or under age 15, are also part of the disadvantaged groups due to their current lack of access to vaccines. We hope this will change, and certainly that is underway in the US due to a recent decision by FDA and CDC. However, that's another group. So altogether, quite a large proportion of our general populations. Housing access and housing quality disparities are another challenge. They're compounded by small homes, often containing multi-generational families and close living quarters. In some countries, there's a lack of health insurance, wage-based occupations. All these are examples of conditions creating health vulnerabilities and therefore health disparities, and are often seen in marginalized communities. These disparities can be compounded by other matters such as lack of safe water and basic sanitation, lack of safety in the community, poor built environments, and poor local transportation systems. So who are in such marginalized communities? We need to, we as researchers, public health agencies, and hospitals and polyclinic clinicians can and must help overcome these disparities by obtaining and protecting data which cover not only key basic information such as gender, age, and residency, but also link these to socioeconomic risk factors for emerging viral diseases like COVID-19. Well, this is a challenge. There are lots of ethical questions here, legal issues, but we need to face this and work towards it. I would say that another way to, another example of this in the Americas in order to address the question of disparities is to look at the vaccination challenge, which you've been talking about. in an innovative project called Shots in the Shop, that is the barber shop. Up to 1,000 barbershop owners are receiving health communication training and partnering, that's online training, and partnering with local health officials and university advocates in the USA to move Black and brown populations, men who come to barbershops, from vaccine hesitancy to vaccine confidence. Through education in a local and friendly social environment. Another project is partnering the LGBTQ plus serving organizations, both nationally and locally, with local health departments around the USA, which address access and build confidence to COVID-19 vaccines through what is called the COVID-19 Vaccine Communications Project, as one example. I'm sure these exist in various countries in Latin America and the Caribbean. Here in this project, they are using behavioral nudges to seek vaccination, to encourage people to seek vaccination in community clinics and local pharmacies. Something can be certainly developed for women and other population high-risk groups, using popular venues for each group. Vaccine lotteries in cities are another that have been in discussion, and perhaps another successful way of ensuring better access to vaccination, along with targeted vaccination campaigns for groups such as indigenous communities, ethnic minorities, and others that I mentioned. So with that, I hope those reflections will be of some use. Thank you.
Well, thank you very much. And I'm glad that you mentioned something that's always been kind of in the back of my mind, is that most research that's controlled by an IRB is done by college sophomores, the convenient sample. You're a professor, you have a captive population. Hey, I'm going to do a survey on consumer preferences. I'm going to do a survey on health. And that's not the real world. So I think in many, many of us struggle with getting data from some of those disadvantaged populations, and that may be a renewed effort. I know it's difficult. I know it's costlier, but that's one of the first things that I learned when I was doing my doctorate. It's like most of the research you read, the surveys are, college sophomores. That's the call the convenient sample. Hey, I'll give you an extra 5 points in this test if you answer the survey. And of course, boom, there's a survey. So that's something good to highlight, to kind of expand the aperture regarding who we study. So thank you very much. It's been a great contribution. This is the second in a row of talking more on the scientific aspect. Now we're going to transition to a little bit more of the economy, national security aspects with Mr. Benjamin Gedan. He's the Deputy Director of the Wilson Centers for Latin America program and has experience in the region. So I think where we're going to go with him is kind of look at some of the economic impacts on the region of the pandemic. So Mr. Gedan, I'm going to first of all welcome once again, and I'm going to go with the first question, which is Latin America and Caribbean's GDP contracted by 6.8% during the 2020 COVID-19 pandemic lockdowns. The economic situation left border communities reeling from chronic shortage of medical attention, food, and also an increase in violence. What are some of the long-term national security implications on the region? Over.
Thank you very much for the invitation, for including me in this important conversation, and for that question. I think it's natural to focus sometimes narrowly on the public health implications of COVID-19 for obvious reasons, and because those implications have been so severe, as previous speakers have alluded to, not only for treatment of this particular disease and its prevention, but on broader resource questions for the public health sector, and on management of other critical public health areas. But I think your question is vital, because the impacts have been equally severe on economic and political matters throughout the region, and the consequences will be similarly long-lasting. The economic impacts were so great in part because of the great vulnerabilities in Latin America. There had already been discussion of a potential lost decade in Latin America, given the slow growth and high deficits and growing debt in the region prior to the pandemic. This had been a period that started more or less around 2014 as a result of declining commodity prices globally and other factors, including policy decisions within Latin America. And so you had great economic vulnerabilities. And as a consequence of those vulnerabilities, you had great political vulnerabilities, again, all before the pandemic. You had high levels of inequality. Latin America was and remains the most unequal regions in the world. And as a result of those persistent inequalities and the slow growth, you had declining support for government and also declining support for democratic institutions. And in fact, not surprisingly then in 2019, again, before the consequences of the pandemic, you had social explosions in many parts of Latin America, including in previously stable places such as Chile that had been seen as models of democracy and macroeconomic management. And so all of these trends are much worse now after a year and a half, nearly 2 years of the pandemic. Governments that already did not have the resources to answer the demands for better education, public health, greater equality, have fewer resources to do so. And the difficulties of managing the pandemic have led even further erosion in support for incumbents and also supports for the region's democratic systems. And so what you have as a consequence of this is all of these very problematic economic and political and social trends that predated the pandemic are much worse. And governments that seek to provide solutions don't have resources to do so. And so you have a lot of uncertainty and inequality and simply political unrest and social tensions really throughout Latin America. And it's not clear you're going to get good policy responses to these challenges, in part because these kinds of situations often breed opportunities for populist, anti-system figures who emerge promising easy solutions, but again, lacking the resources and strategies to provide them. And even those, well-meaning figures who want to provide answers may not have the economic tailwinds necessary to do so. And so I think it really is important for us to consider, even in a public health conversation, the broader context, because this has implications for what resources might be available for public health, and also what kinds of leaders will emerge in the near term in Latin America, who will have to pick up the pieces from this extraordinarily trying period in regional history.
Mr. Gedan, thank you very much for that. That's a very good summary as to what the situation was before. That has been exacerbated by the pandemic. Your last statement is a good bridge to the next question, is what are the long-term impacts going to be for governments? If there's a transition government that comes after this one, what are they going to have to face?
Yeah, I don't think the results politically in Latin America will be uniform, in part because the pandemic, generally speaking, has damaged incumbents. And so who's ever in the opposition could very well see political benefits, which is to say, if you have a conservative government, you might get a government from the political left and vice versa. So I don't think we will see uniform impacts throughout the region, which could have negative consequences in terms of regional collaboration and cooperation, which unfortunately has been quite difficult right now because of a lot of the ideological and political diversity in Latin America. But some trends I think are evident and will affect lots of countries in the region. And I alluded to them briefly in my previous response. That has to do with this idea of political outsiders, often populist individuals, sometimes thought of as anti-system candidates. These are individuals who come in, sometimes without a party structure, often without real loyalty to democratic norms and traditional political institutions, who offer simple solutions, who often want to have a direct relationship with the electorate and not have it intermediated through other elite institutions like the media, but who also will chafe against constraints on their power imposed by courts, for example, or imposed by a opposition-controlled Congress. And so you can have challenges to democratic institutions throughout the region, whether they come from the political left or the political right. And a decline in the quality of democratic institutions in Latin America would not be positive for public health responses to the pandemic, responses to worsening corruption in Latin America, or general economic recovery and the region's ability to strengthen its capacity to, again, meet these rising social demands for higher quality education, security, and public health from the government. And so if you're looking for a cohesive trend, I don't think it necessarily be ideological or political trends, but what you might find is an erosion of the strength of traditional parties, lots of uncertainty that comes from the emergence of figures who are not bound by some cohesive ideology or political agenda from an established political movement. And so you're not certain what direction a country might go. There are lots of examples of this. Peru, I think, is a compelling one right now, where a figure who is very little known just a year ago is now the president of Peru. And so, as he figures out his own political agenda and tries to get along with a Congress he does not control, there's just enormous uncertainty into how, macroeconomic policy will play out in a relatively important economy that is Peru. I think we might see a lot of other examples like that in the region, which will raise a lot of questions about general direction on some key issues. And again, this is not an ideal time for that. The region really does need some consistent policy answers to attract investment domestically and internationally, and to just attract confidence domestically in the trajectory of these countries.
Thank you very much. And absolutely. I mean, Peru's a salient example, like you mentioned, that all of a sudden an outsider comes in, takes charge, and like in previous examples of guys from the left or guys from the right, before they get power, they are very vociferous on what they want to do. And then it's not the same to run for office than to run the office. So they slowly but surely find that out. So now let's transition to the next question, which is, what opportunities does this provide the U.S. government for increased cooperation in the region?
Yeah, I do. I'm quite optimistic about the ability of the United States to support Latin America at this moment. I think, there have been concerns about U.S. leverage, the U.S. influence in Latin America, often in the context of competition with China. And I think the very unfortunate conditions that I've described have a silver lining for U.S. policy, which is to say the region is in great need right now for U.S. investment in infrastructure, for U.S. investment in public health capabilities, including not only the distribution and provision of COVID-19 vaccines, but in the capabilities of the region to provide its own medical resources for this and future pandemic response, and general economic support. So I do think a lot of these negative trends that I have described provide opportunities to the United States to be a more relevant actor in its near abroad, in a region that has traditionally been an area of great influence and importance to the United States. Now, whether the United States dedicates the attention and resources necessary to play that role is not entirely certain right now. I think we have seen kind of mixed response, I'd say, so far. In the initial period of the pandemic, the United States was not the early and significant actor in providing so-called medical diplomacy. Southcom did step up, I think, importantly at critical moments, but I think, widely it's acknowledged that it was China that provided massive amounts of PPE, ventilators, and other early supports to Latin America. Now, granted, these sometimes came with foreign policy fine print and conditions. They were often sales and not donations. I think there are other critiques that can be made, but I think the lesson learned in Latin America was at that moment, it was China, not the United States, that had played the major role. The same was true in the early period of so-called vaccine diplomacy, where again, it was China through sales and again, with some fine print related to issues such as Taiwan, but it was China that was the major provider of vaccines. Now that has changed significantly. And as was alluded to earlier in this event, it is the United States that is by far the major donor, both bilaterally and through the WHO COVAX mechanism for vaccine distribution. And the United States has become increasingly a major, international actor in vaccine distribution and in financing the WHO's efforts. But I think, this is just one of many examples of where the United States has opportunities that it needs to seize. The region right now is not in a position to turn down any international help of any kind. So even in areas where the United States may not be welcome because the United States will come in with conditions related to democracy, will often arrive with conditions related to fighting corruption. I think correctly, if the United States marries those demands for good governance and respect for human rights with the provision of critical assistance, whether that's on narrow but critical public health issues or more broadly on infrastructure support of the type that China has typically dominated over the last several years, I think there'll be great openness to receiving that support. And so the vulnerabilities that we have pointed to in Latin America certainly represent opportunities for the United States to be a major contributor to stabilizing the region and ideally promoting a rapid economic recovery of a type that is not yet projected. Now, the United States, I would say, is focusing on some of these issues, mostly, though, in the countries that produce migrants toward the United States. So the White House has promised very significant investments of $1 billion per year for 4 years, but that investment is narrowly in Guatemala, El Salvador, and Honduras, which are the source, of course, of many of the migrants that have caused a crisis on the U.S. southwestern border. It would have to be, I think, a more ambitious vision for the rest of Latin America if we are to be an answer to a lot of the challenges that we have been discussing, and later will be seen then as a country and neighbor that really stepped up in a moment of great vulnerability and crisis in the Western Hemisphere.
Great summary, and I think that what we call the great power competition, this is going to provide enormous opportunities for U.S. Southern Command and just the U.S. interagency in general to kind of move the needle towards democracy and reduce corruption, as you well pointed out. You kind of gave me a good segue into the next question, and it's what impacts might the entire situation going on in the region have on migration? Over.
Yeah, it will not have a positive impact. I mean, it's had an impact already if you look at the record numbers of migrants who've been arriving. Now, there's lots of factors, many of them related to COVID-19. We've heard about some encouraging figures about the rate of vaccinations in much of Latin America. The regions, though, that are behind are the regions that provide most of the migrants. If you look at countries like Haiti and Guatemala and Nicaragua, these are countries still below 20% fully vaccinated in the population, and other countries in the Caribbean as well. So the countries closest to the United States and those that send the most migrants are also the countries that are really struggling to vaccinate. But there's other factors as well that complicate the domestic economic recovery and lead to greater migration. Some of those are related to the low quality of the democracies. You're about to have a sham election in Nicaragua, a problematic election in Honduras. The kind of hopelessness that is bred in these countries by a lack of decent democratic practices also contributes to migration, as does the high levels of corruption in these countries that lower the quality of government, the quality of public services, and also, again, generate a sense of hopelessness that the countries are not on track to improve living conditions. Climate change is another huge factor. The very devastating previous Atlantic hurricane season with these twin storms that devastated places in Central America, leading to increased levels of hunger, devastating farming that had already been impacted in the so-called dry corridor of this region by prolonged drought, impacting livelihoods in the agricultural sector. So for a lot of reasons, you're seeing increases in migration that are really difficult, for the United States to respond to in a humane way. Some of the earlier efforts by the administration to change U.S. migration policy, I think, inadvertently contributed to these flows of migrants by giving a false sense of U.S. policy and U.S. openness to accepting migrants, particularly while the pandemic continues and restrictions related to public health remain in place. And so I think all of the trends that had been causing migration to worsen in recent years have been worsened even further by the pandemic. Yet another motivation, I would say, for U.S. institutions such as the Southern Command to continue providing support, including vaccination donations from the broader United States government, also the capacities to distribute effectively those vaccines to make sure that public health systems are not ignoring other chronic public health challenges, and just providing general support to countries, even those that may not be on great terms with the State Department, for example, or the National Security Council, over disagreements on corruption and democratic norms, but who still need United States support, both for moral reasons and to address the migration risks. The Southern Command, I do think, is in a good position sometimes to be that partner at times where it is a little bit more difficult or politically challenging for other parts of the United States government to engage. You know, the United States Congress, for example, right now has mandated the so-called angle list of corrupt, private and public sector individuals in the so-called Northern Triangle. Now, this is not a comfortable exercise for elites in those countries, nor the governments of El Salvador, Honduras, and Guatemala. While relations are complicated by questions about corruption and democratic backsliding, there are still great needs, and the United States is still in an important position to be able to provide support. And again, sometimes it does fall to the Southern Command and to the Department of Defense to provide some of that more consistent assistance. And it does help in the short term on migration and in the long term in maintaining relationships and stabilizing some of our neighbors.
Sir, thank you very much for that response regarding, the impacts on migration. I think that on many occasions, as a Southern Command, even if it's not direct assistance, because the U.S. Agency for International Development is normally charged with that, but I think presence and developing relationships are important to maintain in the region, and that's what we've tried to do during the pandemic. It's a complicated situation in Latin America that was just exacerbated by the pandemic, as you well stated. So it's good that we're having this discussion so we can kind of take a deep dive and see the way it's going to move. And hopefully our crystal ball is incorrect, and we'll all live happily ever after, but we know we know different. So thank you very much for your contribution. And we're going to move on now to Colonel Victor Suarez. He is the former Operation Warp Speed Vaccine Program Manager and the former Chief of Staff of Walter Reed Army Institute of Research, or as we well know, we call it RARE. In addition to that, he is now the commander of the 6th MLMC, as we call it, and it supports medical logistics delivery throughout the world. And these are the guys who make things easy for medical logisticians that deliver pharmaceuticals to get them where they need to go, when they need to go. So without further ado, Colonel Suarez, the floor is yours.
Hey, hello everyone.
And I will go ahead and start off. So what are the key, what were any of the key lessons or critical elements with supply chain that could be highlighted if you had to lead an effort to deliver vaccines in the Southcom AOR?
Well, hello everyone, and Dr. Diaz, thanks for the invitation for this panel. What I'd like to say is, let's separate the supply chain in two major areas from my experience with the operation this past year. There's the supply chain that we did in the development phase of the operation, primarily from the May to December, January timeframe. And then as we transition to distribution operations, which we're talking about now, there was a little bit of a different focus. So I want to drill in on really the key critical elements of establishing a supply chain when you get into distribution, especially over a large geographic area. And there's 6 kind of key critical elements that I'd like to emphasize, and I'll give you a couple examples. First, there's plans. I know earlier in this panel, Dr. Aldighieri talked about many of the countries have developed plans, and they've either leveraged some of their pandemic response and their public health system plans, and they've modified them for this COVID response. And so I think that's absolutely essential to have those plans in place. And that is one key critical element that people have to do, but it has to be connected with the other 5 elements I'm going to talk about. And the next one is really infrastructure. And really that's an assessment of the capabilities of your health centers and your clinics, your transportation system versus urban, and what are the various critical infrastructures and capabilities with regard to facilities and even equipment, to include refrigerators versus freezers versus ultra cold freezers, and the various means and modes to move product throughout an area of operation or a geographic area as large as South America, let's say. So infrastructure is kind of that next key element that has to be really looked at in detail, and all the gaps and constraints identified, and then potential resources need to be identified and resourced there for infrastructure. The next is just resources. Now, we're talking anything from the PPE that's needed, the ancillary supplies to actually administer the vaccine is critical. I know we talked earlier in this panel that, you know, you could deliver a vaccine, but if you don't have those ancillary supplies, you're not going to get them in arms in an effective and efficient manner. So it's very important that in the resourcing and the acquisition of vaccine, it's looked at as an entire system, not just the vial itself, that it also has to include resources, funding, the acquisition of all the ancillary supplies to support the vaccine as a system. And that could be as, you know, things like the needles, the syringes. A focus really we saw this past year was really trying to increase capability with more low dead volume 1 ml syringes to maximize every dose you could get out of a vial. So that's, you know, that's one specific area. Then also any of the ancillary supplies need to be paired up with the vaccine so that those site administration sites, the clinics, any site that actually has to administer vaccine in arms doesn't have to worry about whether or not they have face shields or surgical masks or any of the ancillary supplies, just like alcohol pads, so that makes that process as easy and efficient as possible. The next area or critical element is really automation, logistics automation systems to number one, you know, see where your inventory is, place orders, and then direct product to certain locations. That's an absolute critical thing for the operation. What we set up in the country was a very large system that was developed, you know, as we were building it. And that is a key element for distribution, is being able to see yourself while you're doing the distribution, and then also monitor the progress from end to end in that supply chain. The next critical element is operations and control, establishing some sort of redundant operations center so that you have day-to-day current operations so that you can track what is going on. You have also established operations and call centers that can answer questions and redirect requests for information that may come up from a variety of countries, health departments, even medical systems. And there's many layers in that, in establishing operations. So for example, in Operation Warp Speed at the national level, you know, we had a vaccine coordination center and a vaccine operations center. Those operated 24/7 in Washington, D.C. out of the HHS building, and down in Atlanta with the CDC. Those two at the federal level plugged in with the various CDC region teams that were embedded in the various states, so that any information or any questions or concerns that would derive even down at let's say a small community hospital could get quickly escalated if necessary and coordinated for information all the way up to the national level. What we also saw on the private side was they also established call centers themselves as they transitioned to commercial operations. And those call centers were absolutely critical, not only for the distribution, for example, in the United States, with McKesson being the main distributor for any, let's say, deviations of vaccine distribution, but also the pharma companies establishing their call centers dedicated to the COVID-19 vaccines for providers that had questions and for maybe losses or excursions that you would see once product was at a health organization and once it was in storage, let's say. So it's really important to have that operations and control as a critical element. And then finally, I think this is really, really the lesson here, and it's rehearsal, right? In order to have a very good sound distribution plan, you have to be able to rehearse it. And so one example we did throughout the entire fall of 2020, starting in August, going all the way through December, is we had weekly tabletop exercises. These were sessions that went in depth on delivering and walking end to end each one of the products that we projected to be ready for emergency use by December, and then the third vaccine sometime in February. We had regular rehearsals, internal and then with our partners in the various states. And I think this is an area that is absolutely critical when you're doing any type of distribution, is to rehearse and identify those gaps, the constraints, potential solutions, so that you can air them in advance before you go into execution. So I'll turn it back over to you, Dr. Diaz.
Well, thank you very much for that answer. As a part-time medlogy, I know exactly what you're talking about. And I was told very early on in my planning career, those who fail to plan to fail. So I think the bottom line is planning and rehearsal is the key to be able to execute a sound distribution plan. So thank you very much. Now, can you discuss the whole of government and public-private partnership approach that was adopted by the government, and how this same approach could be adopted by countries in the Southcom AOR? Over.
Sure, I can take a crack at describing how we established the operation back here in May of 2020. What I'm not sure about, and I'll try my best to see how something like that could be established in the Southcom AOR with so many countries, but I'll take a crack at it. So just to give you really kind of a formal description of how Operation Warp Speed was established back in May, it was really a partnership amongst many components of the Department of Health and Human Services, including Centers for Disease Control, the Food and Drug Administration, the NIH, the Biomedical Advanced Research and Development Authority, otherwise known as BARDA, and the Defense Department, or DoD. We engaged multiple private firms and other federal agencies, including the Department of Agriculture, Department of Energy, Department of the VA, and various federal law enforcement entities such as the FBI, U.S. Marshals, Homeland Security, and the Department of State. This operation really coordinated existing HHS-wide efforts for therapeutic and vaccine development. So these things were starting to kind of organize, but what was realized was the scale at which we needed something. We needed to establish something akin to a joint task force to prosecute a war against a deadly virus. And that's kind of why the operation was established the way it was, with the general officer kind of in charge, with a chief science officer or advisor selected all, together to kind of lead this effort as an operation. So the key, I think, on how this could be done similarly in another country or another set of countries is whether the country or countries are willing and able to establish an organization by selecting the right leaders that are empowered to take action, they're funded, and that they have the priority and authority to move through large bureaucratic processes. And I think that was the unique thing with the Warp Speed task force, was that it clearly designated mission command to General Perna and Dr. Salui, even though they reported to the Secretary of Defense and the Secretary of Health and Human Services, and then ultimately to the President. It allowed them as a team to execute this mission with the priorities, the funding, and the authorities necessary to bring together all these government entities and have a partnership with the private entities as well. So it must have this clear unity of command as in an emergent situation like we had last year. Decisions by committee may be too slow for certain types of operations. And so, especially during the development phase, and I want to distinguish, that was a different type of organization that was needed at that time through, EUA of the first couple of vaccines. Now, this doesn't mean that the leaders that are selected aren't held accountable. It's just that they must be given that unity of command in a task force-like environment, because we saw this as really a world war against a virus, and that was clearly how this task force was organized. And bottom line is that these task force leaders had to still be accountable to cabinet level leaders, like I mentioned, like the SecDef and the HHS Secretary, and ultimately to the White House. And so I think that was an important thing in the structure. That if anybody's looking to undertake, I think the authorities and the funding and the empowerment of such an organization is really what is needed in the design. Over.
Well, sir, thank you very much for bringing up those 3 points that are crucial, because you can have the authority, but if you have no funding, there's nothing you can do. And, you know, just the unity of command. I hate to use the analogy of a military organization, but it is true. You need somebody that is in charge and accountable. And that was a success, and that's a lesson learned for everybody in the conference. So as we know, Operation Warp Speed was what a lot of people say is the fastest pursuit of a safe and efficacious vaccine in history. What were the original obstacles that OWS had to overcome to convince pharma to undertake this project? Over.
Yeah, so I want to also qualify that too, and just say, look, of all the regulatory agencies across the world, they all do a really good job. But I will tell you though, you know, FDA, they're on another level as far as the scrutiny, and especially when we come to, you know, consistency of manufacturing and those various controls at the FDA. And so, you know, there was plenty of other vaccines that were developed all over the world, but not all those vaccines could get authorization in the time frame that many of the companies wanted to under the FDA guidelines that were published in 2020, and then even for EUA, a policy back in 2017. So I want to qualify that and say that, you know, getting it through FDA was no insignificant feat for the time frame that was done. So going back to the question, so pharma was well on their way with getting after therapeutics and vaccines. But the key, in my opinion, to getting pharma to participate in this effort as it formalized in the spring of 2020 was to lay out a very bold vision, a very clear and bold vision to deliver safe and effective vaccines by the end of the year. And the USG had to commit funding at risk to do scale up of manufacturing while these companies were going into phase 2 and phase 3 clinical trials in the spring and summer and fall of 2020. So that's another, you know, theme that goes over and over again is that funding had to be in place in order to get, you know, industry to say, yeah, I'm all in, let's do it. Now, not all of them had the ability to do it. So that's why, you know, you didn't see, you know, 10 or 15 companies with vaccines in the portfolio. There was clearly some requirements that segregated the pack from each other. And as long as the companies and their boards assessed that they could at least break even, just about all wanted to participate if they had this capability. One thing I think, if you notice across the portfolio, at least of the 6 vaccines that stayed in the portfolio, there was one that had dropped out during the project. All of them had some level of integrated biotechnology manufacturing capability. Even the 2 smallest players, if you look at Novavax and Moderna, even those smaller companies, and they're really small in comparison to the Pfizers, of course, the Sanofis and AstraZeneca in terms of size and capability. Those 2 companies, what separates them apart from a lot of the other small category biotechs with maybe promising technology, is they had pilot scale bioproduction facilities that could scale up if they needed to for mass production of vaccines. And I think that was a critical element, is investing in the manufacturing at the pilot scale, and having that integrated in the company makes them a lot more competitive for being in the game, quite frankly. So I think the other thing here was, by selecting Dr. Monsef Salawi as the chief advisor, you know, he's a former senior vaccine executive at the GSK. It provided the right balance in advice and representation at Warp Speed, and it enabled the pharma company execs to have some level of confidence and trust that there was a very highly competent and very experienced vaccine developer at the top of this operation, along with General Perna. And so those two gentlemen together provided a lot of that trust, I think, to pharma when they got to meet with them. I mean, General Perna wasn't really a known entity within the biopharma space, but Dr. Salawi was. And, you know, he could literally call up any CEO across the world, and he'd get them on the phone, and it just made things a lot easier for the companies to participate with bringing in Dr. Salawi. Over.
Thank you very much for that rundown, sir. We're going to transition to the final question that we have is any final suggestions you may have on public-private partnerships. What are the pitfalls, and what are the good things, that some of the things that can be done to avoid the pitfalls of an unsuccessful partnership?
So public-private partnerships are, you know, absolutely. It's really, there's a couple things that we see, you know, themes with successful private and public partnerships, and one of them is really the public entity really needs to understand. Well, both the public entity and the private entity really needs to understand their particular strengths and their role within the public and private partnership. For example, you know, industry brings the risk taking, the innovation, and the technology development, right? And the government brings to the table the ability to provide funding and to also remove a lot of potentially bureaucratic hurdles. It has the leverage, especially at the federal level, to enact you know, legislation. It has the ability to remove rules or regulations that hinder things. I'll give you an example, right? There was in the project, a lot of people didn't know this, you know, everybody knew that it was hard for international travel, right? So if you were a European person and you wanted to travel to the United States in the summer of 2020, you really couldn't come into the United States. There was just really a lockdown in movement and flying into the United States. However, we had the ability through the organization and through that partnership with various you know, entities, with the State Department, Department of Homeland Security, to get critical workforce members into the United States with really quick order to stand up manufacturing capabilities and, you know, certain engineering expertise to stand up capabilities here in the United States when that expertise resided in places like Switzerland or Italy. And it was that partnership that we had with the federal government in utilizing the authorities we had to meet a requirement that the companies had, because the companies were trying to get these people into the country on their own, and they were just dealing with hurdles after hurdles with getting visas and approval, and it just wasn't going anywhere. But by having that partnership where we focus on our individual strengths and what we can bring best to the table, what we found was we ended up being able to actually you know, produce, you know, better outcomes that way. The second area is really creating a shared vision of a short, midterm, and long-term success in order to create actionable priorities in a public-private partnership. So both entities, the public and the private, really need to sit down and be able to say, okay, what's my near-term short vision of success? What's my midterm vision of success? And then long-term. So in the case of this, let's say the mRNA vaccines, right? The short-term vision of success may have been, hey, we need to actually get something through the regulatory process. We need to develop something that's safe, efficacious, and meets the FDA requirements for EUA. And we need to do it by this set date, let's say December. The midterm might be, what we need to do is then ramp up, you know, the manufacturing scale so that we can deliver X amount of hundreds of millions of doses by this time frame in 2022 to actually change the dynamics of where this pandemic is going, because we are concerned about variants, we're concerned about second and third waves. And so we need to agree on what that requirement is in the midterm. And the long-term success is, hey, if we can get these vaccines licensed, this platform is promising in the long term for potentially addressing other infectious diseases, other ailments that people have. And that might be a long-term benefit to can change the trajectory of health globally from a long-term perspective. And if we can understand those, shared visions of short, mid, and long-term successes, it allows the relationship to better put things in context when there might be areas of friction or disagreement. The next one is really having transparent communications and expectations. That's with any type of relationship you're going to have, but just having clear channels where you can talk freely and actually even have disagreements. But actually, if you realize what the mid and long-term success requirements are, it makes those disagreements and those communications a lot more open and honest, because you already know together you're aligned in what you need to do in the long term and the midterm. So it makes those tough conversations a little bit more palatable. And then really, I think the final thing I would say in a successful public and private partnership is really the focus and the challenges is to spend more time being transformational than transactional. Now, I get it. You're going to have to be transactional. You're going to have certain deliveries that are required under a contract, and there's going to be some hard things that you're going to measure and expect results on. But you've got to spend a lot of time on doing the things that are transformative, the things that actually advance the technology, and the things that actually will make a difference to driving success. And that requires a lot of transformational dynamic discussions and allowing for people to speak that would otherwise might not be able to speak because maybe of their lower rank or their position as like a junior engineer on a project. You need to be able to allow that inclusive discussion and leadership in order for transformation and transformative things to happen. And I think that is another final area, I think, of a public and private partnership success. Over.
Colonel, I want to thank you very much, because you kind of summed up what it is that we in the U.S. government too can learn from public-private partnerships. I know this was very successful, but on many occasions we're not as successful. I think the urgency kind of drove the transformational activities instead of transactional, because everybody was feeling the pinch. So I think that it's very good that you pointed out what success looks like and what right looks like, because this is not the first and will not be the last pandemic, and not the last public-private partnership cooperation. So I want to thank you very much for your contribution. I think this panel has been fantastic as far as what some of the lessons learned are. And I'm going to pass it over to Captain Sears, who just came back from her meeting with a 4-star. We all know, 4-star calls. She'll be there. So she is right here to say closing remarks and then pass it off to Mr. Vitor. Thank you.
Good afternoon, everyone. Thank you very much. First of all, I would like to thank thank FIU for hosting this virtual conference. We do hope that our next conference will be able to be a hybrid, so we can actually see some people in person, which will be wonderful to do again. And thanks to everyone on the line who has helped us make that a possibility, because without vaccines, without public health, and without a stable economy and political systems, that would not be the case. I'd also like to thank our team here, especially Ms. Abuala and Dr. Diaz, for all their hard work making this occur. And most importantly, I would like to thank the speakers. So all of you really have highlighted the fact that this is a very complex issue. This has multiple contributors as well as consequences, whether that's economic, political, all the relationships internationally and within our own countries, the interagency. This is very complex. And I think in the healthcare space, you know, I think we, as Mr. Ault had sort of alluded to, I think to some extent we all saw this coming someday. We did not probably see it coming as soon as it did, but it's really these relationships and these partnerships that help us get through, and keeping those goals in mind are very important. Lastly, I would like to thank everyone who attended. This is just so wonderful to get to meet with everyone again and really see all these different perspectives from this complex issue. I do agree. I think the future looks bright if we can maximize vaccination as well as public health policy in the Americas, kind of put away some of our differences and focus on the goal. Then certainly these mRNA vaccines in particular can be potentially an answer to many of the things which have plagued us. And so the future is bright, and we really appreciate all of your relationships, all of your partnerships here at Southcom. So with that said, I'd like to turn it back over to Mr. Bruce Vitor. Again, thank you so much, everyone. We really appreciate it. And hopefully next time we'll be in person, or at least hybrid.
Thank you very much. Well, Captain Sears, I think summarized very well. Again, I just echo thanking U.S. Southern Command for the opportunity to work with you on this panel. For Wally, Diaz, Dr. Diaz, thank you for the moderating and the excellent questions. Certainly the panel for breaking down the problems very succinctly and clearly, and adding context to the overall challenges that go with this, and sort of giving us an idea of some of the behind the scenes things that are going on and how we got to some of the progress that we've made to date, and the opportunities that are ahead based on those lessons learned that we have here. So again, for a reminder for everybody, this is being recorded. So we'll be hanging this on the Security Research Hub that's from FIU in sponsorship with U.S. Southern Command. And you can find that at srh.fiu.edu, which we'll put in the chat as well to find that and to get more information, not only with this panel and recording, but on other data research and information on COVID and pandemics and other security challenges that are far-reaching throughout Latin America, the Caribbean, and our global issues as a whole. So again, thank you everybody for your time today and your participation. So this concludes our Pandemic Lessons Learned in the Americas panel. And I hope you all have a good rest of the day, and thank you very much.